This program is a presentation of UCTV for educational and non-commercial use only.
Welcome to the University of California, Davis Health System. Since 1973, continuing medical education, CME, has been an integral part of the educational mission of the UC Davis School of Medicine and Medical Center. The Center for Health and Technology, CHT, increases access to health education and promotes interaction between patients, physicians, and other healthcare professionals through the use of telecommunications and computer technology.
Hello, I'm Dr. Jeffrey Applebaum, and I'm returning once again to have a chance to talk about psychopharmacology and primary care psychiatry. I'm primary care medicine, and I perform primary care psychiatry within my practice, and I've been doing this for many years, 15 years with the university. I'm associated with UC Davis Medical Group as Assistant Clinical Professor, Family Practice, and I've also, because of my interests, obtained a Master Clinician Certification in Psychopharmacology from UC San Diego and Dr. Stephen Stahl with the Neuroscience Education Institute. I have a great deal of interest in psychiatry within my primary care practice. Because of that, I've also chosen to do some speaking around the country, and I've spoken for Forest Laboratories as well as for AstraZeneca on topics of psychopharmacology. The topic today is a very interesting one that's interested me for over 30 years, and in the last 15 years with UC Davis, I have tailored my own practice to be able to see patients regarding bipolar spectrum disorder. So today we're going to talk about the diagnosis and treatment of bipolar spectrum disorder, an overview for primary care providers. The issue here is that each of the statements that I make could be discussed in much greater depth, but to give you a global overview, I need to gloss over some areas, knowing that there's a great deal of complexity down to even a cellular, structural, and microscopic level for evaluation and treatment and the understanding of medications. But for the purpose of this discussion, we're going to cover a great deal of territory with diagnosis and treatment both, so I give you an idea of what you can do within your own office. So before we move ahead to treatment, obviously if you're going to defeat the beast, first you must find it. And the beast here is bipolar. And no matter who treats this condition, people tend to miss this diagnosis, whether you're physician extender, a physician in primary care, or even psychiatrist, and even I've dealt with the Mass General Hospital and even their bipolar study group and their clinic for research have missed these types of patients. Why the difficulty? And that's the reason why I wanted to talk with you today, because this is the #1 missed psychiatric diagnosis in this country today. Both underdiagnosed and at times overdiagnosed. This is a very seductive diagnosis for many, and it can be easy to make this diagnosis, but you have to have certain clues. And what I've developed, I've covered in the last 2 lectures that I've given over the past year, and I've developed an algorithm that you see in front of you here today. And this algorithm has been meant to allow primary care providers to be able to make the proper psychiatric diagnosis for most of the common conditions within a 15-minute office interview. And this may seem preposterous to some. How can you get this amount of information from a patient and make a proper diagnosis of a disorder within a 15-minute? But let me give you some examples that I've done in the past and go through 4 decision points. And this will allow you to, if you take nothing away other than this algorithm, you're going to be farther ahead. When you see most psychiatric patients, they're going to present with either depression or anxiety, or typically both, for no matter what psychiatric disorder you're dealing with. And in this situation, if patients tend with their anxiety to worry, and you discuss this worry about the future with them, there's the clue that you're dealing with an anxiety disorder. In other words, worry about the future suggests an anxiety disorder. When patients dwell in the past and have regrets about the past and issues that they can't move on from the past, there tends to be your depressive disorder. If you feel the patient has an anxiety disorder, it's usually one of 5 that I've listed on this slide right below. Generalized anxiety disorder, approximately 6 months of pervasive, widespread general anxiety. Panic disorder, in which panic attacks occur for no apparent reason. Social anxiety disorder, in which people are fearful of others and of being judged. Fearful of getting into situations, of speaking, of heights, of many other aspects. So other phobic disorders within this as well. And then post-traumatic stress disorder, from some life-threatening event or emotional event that occurred in their lives earlier. An obsessive-compulsive disorder, in which there may be checking and washing of hands and other types of activities that go along with compulsive behaviors. These are the 5 major anxiety disorders. It's important to commit these to memory and to have this information at hand, because even if you make a diagnosis of bipolar disorder, this is not a standalone diagnosis, and typically patients have one of the anxiety disorders to go along with that. Let's assume for a moment that the patient is dealing with a depressive disorder. They tend to dwell in the past more than worry about the future. And now you move on to the third decision point. If this is a depressive disorder, is it bipolar or unipolar? Extremely important, before you ever treat with an SSRI or other antidepressant medication, you always have to rule out bipolar disorder. And I'll go through this in a little more depth in the next slide, but mood lability, rule of 3s, loaded family history, and early age of onset suggest the bipolar disorder rather than unipolar, and I'll cover that in a moment. The last and the final decision point is that if you think this is bipolar, also consider, could this be ADHD combined with bipolar, or could it be ADHD alone? So what you're going to have with the algorithm in a 50-minute interview is to be able to decide whether you have a primary anxiety or depressive disorder. If it's depression, is it unipolar or bipolar? And if it could be bipolar, is it ADHD or bipolar or both? That's the algorithm. And when you practice this, you can typically find patients very quickly that have bipolar disorder. I've done this in patients that have suffered for 30 to 40 years, and within a 15 to 30-minute interview, I've actually started treatment and had them on their way to improved psychiatric health. So if we go back to the algorithm in a little more specificity for bipolar depression, how does that vary from unipolar? In bipolar disorder, there is marked mood lability. Depression comes on quickly, suddenly. Last Wednesday at 3 o'clock, I got depressed after something happened, not over weeks to months. So you see this irritability and lability as the hallmark, 86% specificity for bipolar disorder. The rule of 3s, 3 failed marriages, 3 failed jobs, and 3 failed trial of antidepressants. This is the dysfunction. This is the problem with use of antidepressants. Patients don't do well, and for adults, they typically go through multiple relationships because spouses do not do well dealing with patients with bipolar. 3 failed jobs. Either the patient quits ahead of time or is fired, and often works alone even in the early 20s because they can't work with others. And typically antidepressants for bipolar will make patients worse, either by switching into hypomania or mania, or just simply not working and giving a great deal of side effects. The third of the issues here, of the steps that I'd like you to take, would be to shake the family tree. It is so important in primary care medicine to take a good family history. And while primary care physicians and others do, with regard to diabetes and heart disease, often they forget about the psychiatric family history. That's what's so important here. Because when you have a patient with bipolar, you will actually see others with bipolar, even siblings and parents. If one parent is bipolar, then the offspring have 25% chance of being bipolar, and if both, it's 75%. Then schizophrenia, alcoholism, substance abuse, suicide, incarceration. The family history is absolutely loaded. And very often, when I see patients and take the family history, I ask, did you share this with a primary provider in the past? And they say no, and when I ask why, it's because that provider never asked. And if you don't ask, patients don't tell. And the last is the early age of onset. Typically, childhood or early adolescence is when you tend to see bipolar, much more so than unipolar disorder. And remember that 60% of patients who have bipolar disorder will have some manifestation by the age of 19. When you look at bipolar versus ADHD, you want to look at the core feature, and that's what we're doing with basically the entire algorithm. What is the core feature of bipolar disorder? It's bipolar affective disorder. It's a core feature of a primary mood disorder. ADHD, on the other hand, the core feature is a cognitive disorder. Attention deficit hyperactivity disorder, really a misnomer. It's really attention inconsistency. And if a patient likes what they're doing, they can pay attention. If they don't, then they don't. But the main feature here is not a mood disorder, it's a cognitive disorder that, when not treated, then goes on to depression, anxiety, oppositional defiant disorder, to conduct disorder, substance abuse, typically marijuana. And so you're going to get a different feature. Bipolar disorder is often seen in the early teens. If I were going to pick an age, I'd say 13 or 14. ADHD, typically 6 or 7. So who do I screen for bipolar disorder? This is a fairly comprehensive list here. Every person with depressed mood, every person with generalized anxiety disorder, people that have behavioral disruptions, people that abuse substances. And the FDA Health Advisory advised strongly to screen for bipolar disorder before initiating any antidepressant therapy. You need focused diagnosis to have focused treatment. The biggest fault that I see is that primary care providers often will lump depression and anxiety as a single entity and then treat for both. But if you don't have the focused diagnosis, you're going to be heading in the wrong direction much too often, with sometimes pretty dire consequences. So if you're going to look for depression, I like to go back to a couple of the mnemonics that one of the mnemonics I'm sure many of you have had from med school, SIGI CAPS. And 2 weeks of depressed mood with SIGI CAPS equals depression, often major depressive disorder. And that is a unipolar depression when it's by itself. And the S stands for sleep disturbance, typically early morning awakening. Loss of interest, that's the anhedonia. Guilt feelings, loss of energy, that's the fatigue. In fact, when I see patients that are fatigued, unless they have a cancer, hypothyroidism, some chronic disease, I tend to think of depression as the primary problem. And then problems with concentration. You know that when you're feeling poorly, you don't concentrate well, you make mistakes, often lose jobs. Appetite can go up or down. There are often many physical complaints. In fact, if you have 7 physical complaints that you do not have a specific unifying diagnosis, think depression. And the final aspect is suicidality. Suicide is the end result of depression that's not adequately treated. So that's SIGI CAPS. Now, when we talk about unipolar depression, it's just that, unipolar, unipole, one pole. Bipolar means 2 poles, and the other pole from the depression is the hypomania or mania, which are a matter of degrees. So 3 to 7 days duration of elevated expansive mood or irritability with the mnemonic, I dig fast. Think of somebody who's out in the garden, who's manic, and he has a shovel, and what is he doing? He's digging fast. So the I is irritability. D is distractibility. They go and jump from one topic to the other. Insomnia here is really lack of need for sleep rather than cannot sleep. They don't want to sleep. Grandiosity. They think that they're better than the boss. They know more. They can invest in the stock market and make millions. They have all these great ideas, but they typically fall through. And this is part of the plight of the hypomania or mania. The flight of ideas, the jumping from topic to topic. A stands for activities. They take on many activities early on when they're hypomanic. But as the condition worsens, the ability to handle those activities falls apart. Speech, rapid and pressured. I say that it's like having bullets coming out of a machine gun with the speech that comes at you. And thoughtlessness is the risk-taking behavior, maxing out credit cards, sexual indiscretions, losing families and jobs. So many things happen on both sides. The mania, hypomania tends to be rather pronounced, and people often, primary care providers, concerned, but the real disability comes from the depression side, because over time depression tends to become worse, and it leads to increasing problems with focus, concentration, memory, and cognitive decline leads to disability, and from there often loss of homes and families. This is the way people often think of bipolar disorder. You have mania, then in between you might well have euthymia, which means normal mood and focus and concentration, and then depression. This is the way it's been characterized and thought of by many. In reality, you have, depending upon the type of bipolar, that's why we call it bipolar spectrum, and I'll show you a few of the differences in a moment, you're actually looking at somebody who moves from euthymia, which again I would put as a misnomer. People really don't have normal mood in between, and I'll explain that a little bit later when I talk about treatment, because it's critical to understanding why you want to put somebody on long-term therapy and maintain that therapy. They may go into depression, mania, subsyndromal depression, another episode of depression, hypomania. It really depends on the type of bipolar spectrum. Remember that we categorize these conditions as disorders, not diseases, because we put together a set of symptoms and a set of types of behaviors and call that a disorder. It's not necessarily tied to one specific pathologic diagnosis that you can prove at a cellular level. So as a result, we have to look at the spectrum of a disease rather than, or a disorder, rather than one condition. In reality, more than that, here's the way it really is. This is the real course of bipolar disorder for so many. Look at the chaos, the mood swings, the changes, and when you're thinking of that, I don't want to scare you away from treating, because once you start some counseling and medication, much of this can smooth out. It doesn't smooth out totally, but you often have a major impact, and enough to keep patients in jobs, in families, working, and doing well for years. So don't be scared from looking at something like this, because people say, I don't want chaos in my own practice. You'll find that these patients will be extremely rewarding and grateful to you. So one of the things you have to do once you come to a diagnosis of bipolar disorder is realize it's never a standalone diagnosis. So as soon as you've made that potential diagnosis, and remember, it may be a tentative diagnosis, you may not be certain of the diagnosis, but you start treatment based on your initial thoughts. You always want to look for an anxiety disorder. It could be panic disorder, it may be OCD, it may be a generalized anxiety disorder. Typically, you'll also see drug and substance abuse, and that will complicate matters. Some people will say, treat the drugs and alcohol first and then take care of the psychiatric problem. I see it the other way around. If you don't take care of the psychiatric problem first, you never will get a good handle on the drug and alcohol treatment. Psychosis is much less common. In fact, when you deal with psychosis, if it's associated with a depression, especially a unipolar depression that's severe, in a sense that's a good sign, because when you treat the depression, the psychosis goes away. In bipolar disorder, it's typically associated with the manic phase. And then if you have psychosis without any mood disorder, or any substance abuse or delirium, then you start thinking of schizophrenia, and that obviously is a much more difficult diagnosis to deal with, and we won't be dealing with that here today. Aggressive patients consider comorbid and the need to control that aggression, which often puts people in jail. ADHD may be comorbid in as many as 30 to 40% of cases. And then borderline personality disorder, which is another separate diagnosis, but I would like to just say often looks very much like bipolar. May coincide, but again, maybe two separate disease processes, and I'll leave that discussion for another day. When you look at the bipolar disorder by age, you'll see that by the age of 19, you have approximately 60% of patients that have demonstrated a mood disorder. That doesn't have to be typical depression followed by mania or hypomania, as you think of in adults. You may see a great deal of irritability, worsening of the typical teenage years, more substance abuse, behavior that just doesn't make sense. And it may not be your typical manic and depressive symptoms. Typically, there will be some aspect of depression. And so when you see teenagers that seem to be getting worse each year, that is a sign that you're dealing with a psychiatric disorder within that adolescent. Because normal teenage years, adolescents should get better each year. And I often warn patients, and especially their parents, that when you don't treat what I consider to be a typical psychiatric condition at the age of 9 or 10 or 11, it will get worse when the sex steroids start around 13, 14, and then typically worse again at 15, 16, 17. And at 17, 18, when teenagers want to be independent and say their parents are like policemen and they feel like prisoners in their own home, physicians often come to me in my own office and say, what can I do to take care of this teenager now? And I say, you could have treated when they were about 9 or 10. So if you don't treat early, you're going to pay a hefty price later. And that's for the parents to understand as well. I tell parents that a parent is only as happy as their least happy child. And I think that's a good take-home message for you as parents or for your patients, because all it takes is one unhappy child in a family, and that family is often in trouble. So when you do screening, if you don't ask the specific questions yourself, you can use some checklists. The PHQ-9 is a 9-symptom checklist for depression, often very helpful. And it's a very simple one, tear off piece of paper. You can give this to the patients either in the room or the waiting room. That's fairly easy. The other, if you don't remember the I Dig Fast, you can use a mood disorder questionnaire developed by Robert Hirschfeld and well tested. And this has gone out to over 100,000 patients in the United States in the past, with results that really confirm that about 20 to 25% of patients with depressive symptoms actually have bipolar disorder, not unipolar. And this was confirmed by his testing. There are 3 basic questions. The first one asks questions that have to do with hypomania or mania, and if 7 of the first 13 are positive, that suggests a positive mood disorder questionnaire. The second one asks if several of these things happen, do they happen at the same time? The answer, yes. That goes along with a positive MDQ. And the third is how much disability do you have because of this? It could be severe, mild, or none at all. If it's the moderate to severe, that suggests a positive MDQ. Remember that if the patient fills this out themselves, this will not be as accurate because the patient does not have the insight. So I try to get somebody along with the patient to help fill that out. If that is a positive MDQ and the patients have depression, irritability, you think they may have bipolar, this has a 93% specificity. There's only 7% false positive. The false negative rates run about 40%. So if it's negative, it's not as helpful. But if it's positive, you have very small false positive rates. So let's look again at bipolar versus unipolar depression, because no matter how much I talk about this, you'll go back to the office, as most physicians will do, and 3/4 of the time you will be seeing unipolar depression. And the bipolar often blend in. So what we want to do is look at a number of factors here. Try to think on substance abuse. If there is bipolar, tends to be very high with substance abuse. Family history is loaded for mood disorder. That is going to be more in bipolar. First episode before 25, much more common in bipolar. Seasonality, typically depression in the winter months and mania in the spring and especially summer. High recurrent depression, much more common in bipolar. The antidepressant misadventures in which the antidepressants don't work or make the patient worse, much more common in bipolar. Rapid onset, on-off pattern, common in bipolar, very uncommon in unipolar. Postpartum depression, much more common to have bipolar suddenly show up as a severe depressive episode, and first recognized bipolar in the postpartum state. And finally, mixed depression with hypomania and mania, much more common. Bipolar, very absent in unipolar. And remember, on the postpartum depression, some physicians in the past have been of the thought that pregnancy will protect people against bipolar disorder, and that's very much not the case. So patients that are pregnant need to be treated who have bipolar depression during their pregnancy. Otherwise, there are some pretty dire consequences for both mother and child. Again, another topic that we could talk about in much more depth at another time. So how do we divide this bipolar spectrum disorder? If we talk about an episodic, infrequent episode of mania followed by depression, it may be once every 2, 3, 4 years. A major episode of mania, that's the I dig fast, and followed typically by a depressive episode. That tends to be your bipolar 1. The mania, often severe, lasts perhaps a week, may take a few weeks to burn out, and then head into a major depressive disorder. That is bipolar 1. Bipolar 2 is much more frequent and not as episodic. It's more continuous with ups and downs. There's a lot of instability of mood, hypomania rather than full-blown mania, the irritability. It's that I dig fast at a much smaller level for a few days at a time. Patients say, I will know that I'm doing well, I feel good, I get a lot done, but I know then I'm going to have to, quote, pay the price. When you hear that, realize that paying the price for feeling good is the depression. And patients don't like to be depressed. It's, again, major depressive disorder in bipolar 2. So what the physician may see is the depression, not recognizing that there was another pole, the hypomania, or in some cases, mania. But bipolar 2 is often what we see in primary care, not the bipolar 1. If you look in practices typical of primary care, the bipolar 1s are going to be with a psychiatrist. We see the bipolar 2 that are not coming in the door, that are already in our practices. And when we talk about cyclothymia, these are mild levels of depression, mild levels of hypomania. It comes and goes, unstable mood. Patients that have these eggshell personalities, they go up, they go down, and they're hard to live with. These cyclothymic patients can go on to more full-blown bipolar, but again, varying mood. The brain is not controlling the mood in a way that would be normal. And then bipolar NOS fits for all the others. Many of these are patients that have a great deal of irritability, but they don't fit the criteria for hypomania or mania. They may have major depressive disorder. So the one characteristic is that the primary care provider sees the patients when they're depressed, and the rest of the world sees them when they're hypomanic or manic. We have to look for that other pole. That's the critical feature. The workup is fairly basic. I always get a workup, and it's important to follow up patients because when you use the medications that you need to, you will need to follow up blood sugars, lipid panels. Many of these patients will have comorbid diseases such as diabetes. Hepatitis C is very common. All the patients should be screened for hepatitis C. Thyroid disorders. In fact, when you have hyperthyroidism or hypothyroidism, you want to look for, is there concomitant psychiatric disorders in these families? And on the reverse side, patients that have a strong family history of psychiatric disorders often have an autoimmune thyroid disorder like Hashimoto's. So you get a CBC, a comprehensive metabolic panel, follow up a free T4 and TSH both. there are some subtle changes that you want to be able to follow. Urinalysis, lipids, hepatitis C, get a vitamin D level. Most of the patients are low. Patients do better if their vitamin D is normal. You can consider other testing based on the history. And then remember, if you're going to be following these patients, you also want to make sure that in a few months, if you're putting on for example, an atypical antipsychotic medication, you want to make sure you follow up blood sugars and lipids. So when patients have depressive illness, they have a chronic state of inflammatory changes within the body, not necessarily visualized, but could be picked up metabolically. The HSCRP is often elevated. We know that there are elevated cortisol levels, glucagon levels are elevated. All the stress hormones tend to be elevated in patients with depressive disorders that lead to multiple other conditions. I list these here as a sidelight: 20 to 40% prevalence of depression with cancer, stroke, heart attack, Parkinson's, Alzheimer's, diabetes. I tend to want to treat more aggressively because patients with the medical conditions typically do better if they're treated with appropriate medication for their psychiatric condition. If you don't ask, patients may not say anything. Families will suffer, and so will the patients. And then there's higher recurrences of things like stroke and myocardial infarction. So what's the consequence of not recognizing bipolar? What you're seeing here is a standardized mortality ratio. Every condition is compared here: neoplasm, cardiovascular, cerebrovascular, accidents, suicide, all causes. The red is untreated bipolar, and the turquoise is treated bipolar condition, compared to somebody without bipolar, who we consider normal. What stands out is suicide. 29 times higher condition of bipolar disorder suicide as compared to the normal population. That's untreated. If treated, it is still about 6 times higher level of suicide in your bipolar patient. So the number one cause of suicide in this country today is bipolar disorder. That's important to recognize this. 30,000 suicides per year in this country. That means about 1 suicide every 15 to 20 minutes in this country, round the clock, every day of the year. This is bipolar 1, 29 times higher. I often ask groups, what do you think? Is bipolar 2 higher or lower than bipolar 1? We often think hypomania, not as severe as mania. The actual suicide rate in bipolar 2 is higher than bipolar 1. And the reason is that the bipolar 1 patients are often diagnosed fairly readily because of their manic type of behavior. They're recognized more easily. It's the bipolar 2 that are in our own practices, yours and mine both, that may be unrecognized and that lead to suicide before we actually pick up and make the correct diagnosis. So if you have a bipolar 2 in your practice, even if you're not treating them, they're at much higher risk of suicide, with impulsivity and depression. Typically, the suicide occurs during the depressive phase, not the manic phase, or perhaps in a mixed phase where there's both depression and hypomania or mania. So if we move on in the last half of our talk to the treatment of bipolar spectrum disorder, I would say that when you hunt in tiger country, you better have the right weapons. And so there are a variety of medications, and I'm going to cover the medications today much more so than the counseling. I counsel my patients. I send them for counseling, and it's very important to have the counseling along with the medication, both, because the medications in no way are curing all of the ills and the difficulties that these patients have. But without the medication, you can't get adequate treatment, because the mood stability and instability is too much of an issue. So the first thing we often look for are mood stabilizers, and we have to consider there's 2 types of mood stabilizers. One that are mania-minded treatments. What does that mean? That means if they're going into mania or hypomania, we want to treat and control the upside. That means when the patients are running too hot and they're having all the problems of distractibility, grandiosity, flight of ideas, impulsivity, over-shopping, sexually hyperactive, getting into trouble with the law. We want to bring that down, often in a crisis situation, and we treat from above. We also want to stabilize the patient, again, on that hypomanic side. But when we get into the depressive side, we also want to treat the depression, and we have to treat from below, and we want to stabilize from below so that patients don't go back into depression once again. Here's the difficulty. We have lots and lots of treatment to help with the hypomania and mania. The difficulty is we're much more limited and do a much poorer job on the depressive side. And as a result, the patients over time often get more depressed. And that's where the disability is the greatest. We can do everything right and still have problems in which the patients go on and progress. So because we put them on medication does not guarantee that they will not progress and get worse in bipolar disorder. Patients may do poorly, they may die, but you think about it, we are not really curing diabetes, heart disease, COPD, Alzheimer's. Most of the conditions that we treat, other than the minor ones or infectious diseases, we're trying to help stabilize, we're improving function, reducing pain and suffering. That's what we're doing here in a very big way. Because for each one patient that you treat with bipolar disorder, 1 or 2, you'll be helping in the immediate family, in the immediate circle, 15 to 20 people. And in the bigger circle, hundreds. So if we start with one of the main medications, lithium, and I know many primary care fear this medication, they don't like using lithium. Let's assume for primary care that we're going to be dealing with the medications for bipolar 2, which are the types of patients that we're going to see in our practice. I have many in my own practice, and now within our group, we do have many of the doctors treating some of the more straightforward bipolar patients, and there are ones like that out there. When patients are getting into issues of mania or hypomania, and typically it's going to be hypomania, or mixed with some depression, or cycle much more frequently, then we often can use lithium very nicely. We don't have to go to therapeutic levels, in fact. We can use even subtherapeutic levels. One thing to mention, I'm using terminology. Switching means if someone's depressed, put on an antidepressant medication, and they go from depression into hypomania, mania. That's called switching. If they cycle normally with bipolar 1, that might be 1 episode every several years. If you have more than 1 cycle in a year, typically 4 or more in 1 year, that's called rapid cycling. That'd be 1 every several months. There is also something called ultradian cycling, in which they cycle not only monthly, but daily. And these are often patients that have become destabilized by improper treatment with antidepressants and other medications. So the lithium can be used 300 milligram twice a day and up to 600 milligram 2 to 3 times a day. I often will start at a low to moderate dose. I treat higher dose only when there's a crisis. If patients are working and I can keep them working, I will try to go with the lowest possible dose of medication and work up to minimize side effects. Because if you lose the patient to side effects, you're not helping the patient at all. So it's better to go slowly, unless you're in crisis, and then you have to put the side effect issue to the side and treat aggressively. The issue here is that lithium can help both depression and mania. It can help stabilize and help treat both. It can help the rapid cycling. It can help hypomania and mania. Again, if you're dealing with a purely manic patient, you're going to want to get to therapeutic levels around 0.8 to 1.2. You don't necessarily need to do this when you're dealing with most of the bipolar patients. If you have suicidality, you can get a great deal of mileage out of lithium, 150 to 300 milligrams at bedtime in unipolar or bipolar. And listen carefully, unipolar or bipolar, often the suicidality will go away in 24 hours and stay away, so that you have more time to treat without having to worry about suicidal ideation and behavior. And again, at a low dose of lithium, you're not going to get the patient into trouble. When we look at valproate, and here's the interesting thing, we use our mood stabilizers that we've typically said in the past, the antidepressant is not a good mood stabilizer, but the anticonvulsant is. So we're going to take the anticonvulsant category and use it not for seizures here, but more for bipolar. But not all of the anticonvulsants are good mood stabilizers. For example, Dilantin is not. Topamax is not a good mood stabilizer. However, valproate or Depakote is a very good mood stabilizer. And when you have patients that have rapid cycling, I would look toward this medication in adolescents. And remember, some of the medications that we use in adolescents and adults may not be indicated. And this is the difficulty, is that we cannot do a lot of testing on children and adolescents. So what we have to do is to treat knowing that we have a good body of scientific evidence behind us. And the FDA does not have to approve every aspect of our treatment if we have good scientific knowledge. So we might well use valproate in children, adolescents, and adults for bipolar disorder, especially when there's rapid cycling. In the adolescents and the young women, I tend not to use this medication because it may promote polycystic ovarian syndrome. And so as a result, I stay away from Depakote or valproate in young females. But again, for young males and adults, for rapid cycling, this is a great medication. It can help for depression as well as for mania, for control and treatment both. You can see here, we're treating, we can stabilize, we can maintain. More for perhaps the manic side than the depression, but it does work on both. Here's what the molecule looks like in an icon type format. Sodium for binding, calcium binding, and then glutamate and GABA are modulated through valproic acid. And that's all I'll say about that for now, because many of the medications we use are meant to stabilize membranes, and glutamate is the big neurotransmitter amino acid that tends to activate, and GABA tends to inhibit. And these two make up the majority of the neurotransmitters in the brain: serotonin, dopamine, norepinephrine, about 1%. The biggest part is glutamate and GABA. Lamotrigine or Lamictal is an excellent medication for bipolar disorder. It's one of the best, I would say, my favorite for bipolar depression. It's been recommended by the American Psychiatric Association. Excellent for depression, more so than it is for mania. You have to start slowly. This is the difficult part. You have a patient severely depressed, you'd like to treat the depression, and you might target 150 to 200 milligrams or more of Lamictal, and you have to start at 12.5 or 25 milligrams for about a week. And then a week later, you go up another half tablet, and you're at 50 milligrams at a few weeks, and maybe 100 milligrams at 2 months or 3 months down the road. The problem is, if you go too quickly with Lamictal, there's an increased incidence of the Stevens-Johnson syndrome and rash. And I've seen that at the first dose increase from 25 to 50 milligrams, in which a young lady was covered with the changes in the skin and starting to slough tissue of mucous membranes, and skin was sick for about 6 months. And so you've got to be very much aware that any of the mood stabilizers, but especially Lamictal, can be an issue here. But once you get to the target dose, 150 milligram, 200 milligram, I like to keep the patients on this medication long term, along with their other meds. And I'll talk about maintenance in a few minutes. This is what Lamictal looks like. Again, you see the glutamate, and the receptors here may block or stimulate. In this case, the Lamictal will block the glutamate stimulation to block some of the hyperactivity. Gabapentin, pregabalin, sounds like GABA. Neither one of these are GABAergic, so they do not deal with GABA receptors. They deal with voltage-sensitive calcium channels primarily, and it's the an alpha to delta component of that channel. So again, voltage-sensitive calcium channels are where gabapentin, Neurontin, pregabalin, Lyrica tend to work. And we use these also for pain control, because voltage-sensitive calcium channels and sodium channels are very much involved intimately with pain. When we look at the atypicals, and we tend to call them atypicals in front of patients because the old term, the antipsychotic, patients start to wonder, I'm not psychotic, I'm not schizophrenic, why are you treating me with this type of medication? Well, we use aspirin for many things. We use Inderol and beta blockers for many, and that's what happens with the atypicals. These are very good medications and should be a good part of your arsenal, good in the toolbox, because overall they tend to be quite safe. They are excellent for rapid treatment. They help for rapid cycling. They help for mania. They help for depression. Again, you're going to find, going back to this one for just a moment here, you're going to find that they have a wide spectrum of use. So that if I see a patient that I feel has bipolar disorder, my ultimate treatment will probably be in the range of 3 to 5 and up to 7 medications. And I know at this point, I can't see you all out there, but I know some of you are probably frowning or grimacing, saying, I'm not going to put this patient on 5 different medications. I'll send them to the psychiatrist. Over time, if you become comfortable with rational polypharmacy, it certainly is possible, as you have done with hypertension, diabetes, heart failure, COPD. You know that different medicines for different mechanisms. So lithium on a patient that is having some suicidal ideation. Not all patients who have suicidal ideation have to be hospitalized. Again, this is not going to be on label, I have to tell you, and as long as I label it as off-label, and I've had many physicians come up later and say, wow, this really works. Olanzapine, Zyprexa, 10 milligram, with lithium, 300 milligram, given once by that day, and if you have to repeat the lithium again the next morning, and maybe a little more Zyprexa up to 20 milligrams, will take away all but the worst of the suicidal patients. It will actually take away their suicidality in less than 24 hours. And I've been doing this for years. And patients come back the next day, as long as somebody else is treating them, providing the medication and observing, and they typically do well. So lithium for suicidality, an atypical medication for both the depression and the mania. I start Lamictal early because I know if they're not depressed now, they will become depressed, and I need to take several months and build up the dose. That could be your basis. One lithium, one of the medications atypical. I have to pick a number of different ones. I happen to use quetiapine or Seroquel XR, and I will treat based on the level of symptomatology. I will titrate up to about 150 to 200 milligrams, maybe 300, but I try to get the lowest possible dose and head for about 150 milligram, given 3 to 4 hours before bedtime to minimize daytime sedation. In the acute situation, I've used olanzapine frequently, Zyprexa. The issue there is weight gain, fluid retention, sometimes significant weight gain. So I look these days at Zyprexa as my Marines, and sometimes the Seroquel as the infantry who stay around longer. And so you mix and match as you learn about the different atypical agents. There is Risperdal, there's Geodon, there's a whole host of medications. The idea is find one or two and start to build on that. And when you choose, like from a buffet, you choose an antidepressant and anxiolytic for unipolar. Here I choose perhaps lithium. I might well choose an atypical and an anticonvulsant like lamotrigine. And there's my starter. I see them back in unipolar depression at 3 to 4 weeks, but with bipolar, I will tend to see patients back often in a week or 2 at the latest. If they're more severely depressed, I see them at a week. I'll talk to them in between. When we look at the conventional antipsychotics, the older medication like Haldol, Thorazine, Mellaril, Stelazine, this is the basic mechanism. They have attached, again, when we look at the icon, the major effect is from a dopamine blockade. There are 5 major dopamine receptors, D1 through D5, and this is D2. When we block D2, we tend to take away hallucinations and delusions in the schizophrenic. We help with delirium. The side effects are the muscarinic anticholinergic, the M1, antihistamine effect, H1, alpha adrenergic blockade, which can lead to some hypotension. We use the atypicals these days because there are more effects and much stronger effects with these and much safer. And as a result, we typically do not use the older antipsychotics as we do. If we get rid of all of the extraneous except the D2 and the 5-HT2A, the 5-HT is serotonin 2A receptor, and this is an actual part of the molecule. This one is on the molecule and will bind to the receptor, so this is the binding part of the molecule. And we have a D2. What happens is that the 5-HT2A reduces glutamate hyperactivity. And glutamate, remember, is stimulatory, so it blocks the issue of mania or hypomania. And 5-HT2A also helps increase dopamine just slightly, so that when you block the dopamine hyperactivity with the D2, it's a smaller amount of blockade, and thus patients don't get into the problems that they tend to with the older medication. The Parkinsonian type symptoms, the nigrostriatal pathway that leads to the Parkinsonian walk and shuffle and gait and all the issues that go with Parkinsonism. So these medicines can be used quite safely. Haldol, the older med, would block dopamine at all sites in the brain by about 90%, like superglue. The D2 receptors in your atypicals block about 50 to 60%, enough to prevent the issue of the EPS and tardive dyskinesia, even long term. So what are the clinical actions on our new kind of super molecule, the atypical antipsychotic and bipolar depression in particular? Well, let's take a look. H1 is the histamine binding site for the receptor, and when you utilize the medication, you're treating insomnia. And then the alpha adrenergic, you're improving mood. Serotonin reuptake inhibition, norepinephrine reuptake inhibition, you're improving mood. On the serotonin molecules, you can see here, again, most of these are for mood and cognition. And what are the pharmacologic actions? Well, histamine, antihistamine, alpha adrenergic will block norepinephrine and dopamine, and you have a disinhibition, so you actually are increasing norepinephrine and dopamine in various sites to help. You have serotonin receptor blockade inhibition, so the reuptake is inhibited, and thus you increase serotonin. You do the same with norepinephrine. You improve circadian rhythms. There are a whole variety of other factors that have to do with disinhibition, and that gets into another topic that I think I would let go at this time, because that is a little more complicated for the time that we have. Many of you are aware of Abilify, and this is a partial agonist, which is an interesting medication, because if you have too much dopamine around, as a partial agonist, it will not allow all the dopamine to bind. So you can actually decrease the amount of dopamine at the receptor site when you have too much dopamine around. If you don't have enough dopamine, however, the partial agonist will bind better than none, and as a result, you have a partial effect. So this has a beneficial effect for bipolar and even unipolar depression. So when we look at combinations at this point, I would say an atypical or the partial agonist, which is Abilify, with lithium is a good combination. You can use your atypical or Abilify with Depakote. You have other, and there's a whole host of combinations as time goes on. Lithium with valproic acid or Depakote. You can go to lamotrigine and Depakote, I probably would not use. Lamotrigine and lithium, good combination. And you can use lamotrigine, lithium, and maybe Depakote. Again, using two anticonvulsants from the same category, probably wouldn't. There's also Tegretol and Trileptal, the carbamazepine, and there are a variety of other medications that have been used. Neurontin may provide some good relief of anxiety, but not really good as a mood stabilizer. So when we look at the final approach, when we have a pharmacy, our first line, you have a whole host of medications you can use, and you can pick one or two or even three. I would not tend to use my atypical antipsychotics with the partial dopamine agonist, Abilify. I'd pick one or the other. I would pick from the anticonvulsant category, my favorite being lamotrigine. Notice when you use Tegretol or carbamazepine, that medication may actually stimulate the liver to induce enzymes that break down the other medications and lower their dose. So be careful with Tegretol in particular. Valproic acid, very helpful for young men and adults. Young women, not so much. Lithium, very helpful. In hot weather, just make sure that they don't become dehydrated, that if you're using diuretics, you watch a lithium level if you have a high level to start with. And from there, we move up to second line and third line and even adjunctive. I'm not going to cover all the medications, but just remember that when you're dealing with patients that have multiple conditions, on anxiety disorders, you may well use a benzodiazepine. Stay away from Xanax. I see more abuse of that anxiolytic than any other. Klonopin, a long-acting, would be safer if you're going to use something, and can be helpful. Drugs and alcohol, Camprosate or Camprol for prevention of alcoholism and treatment of alcoholism, really, in this case. Psychosis, we won't deal with much. Aggression, our treatment. ADHD, we can use stimulants, but remember the fact that if you're going to treat a mood disorder and a cognitive disorder, always treat the mood disorder first. You would never start a stimulant medication if there could be bipolar present, because you could destabilize the mood. When you look at long-term medication, you want to look at the fact that my feeling is best to keep patients with bipolar disorder on long-term medication. And the way I look at it is that if I take a normal individual and put them out in the ocean, nice, beautiful, warm day, they have a boat, in fact, a nice cabin cruiser, I tell the patients, and a life jacket. And when there's a storm or sharks, they get on their boat, they weather the storm, back out, experiencing a very nice day. And that's great for those patients. A bipolar goes out in that same ocean without the boat, without the life jacket. So when you talk about euthymia in a patient with bipolar, they are aware that they are going to face storms and sharks without any protection. And what I tell them, the protection is their medication. That is their life jacket and their boat. They need to stay on at least the lowest possible dose. And once they stay on that, they will do better in the long run. They will have confidence. So with that, I'm going to close today. I think that I've covered a great deal of territory. If you're interested, and when you fill out the cmecalifornia.com information, and if you wish to have further topics within the bipolar discussed, please feel free to put that down. We will definitely look at that. And if you have special topics that you would like within bipolar spectrum disorder, or counseling, or further medication, or other information behind the scenes, please let me know, and we'll come back and have another session on this. Thank you very much for your attention. I look forward to hearing from you. And for those of you that might be interested, I'll put up a book, the Stephen Stahl book for psychopharmacology, a great deal of information. We're set for this. This book is a Bible. The second edition was small. This one has grown, but well worth its time, whether you read it entirely or one page at a time. So thank you again, and goodbye.